Good afternoon, everyone. If everyone could go ahead and turn on your cameras, we'll get class started. We have quite a few extra faces in Zoom today because I believe everyone from Dr. Zeller's course should be in for my class. Okay, I'm glad you all found where you had to be. So before we get the quiz started, if everyone could please make sure that your first and last name appears as your Zoom handle. That makes it a lot easier for us when we're doing attendance because I don't want anyone to miss out on attendance just for not having their names. All right. And then if everyone can come into their screen because we're going to get these quizzes started right away. So I need everybody's camera to be on.
Excuse me, Professor. Hello, good afternoon, afternoon.
Why?
I have a question. Do I have to log in through another device?
No, for the quizzes, you guys are okay to just use the one device. For
Okay, so
quizzes, that's only for exams. So exams, you're going to need two devices. For the quiz, as long as you guys remain in your screen, that is perfectly acceptable.
okay, perfect. Thank you.
You're welcome. Does everyone know where to find your quiz? Has everyone found it?
Not yet.
Okay, so you go into your Canvas and it should be under your module two. And then you'll just click into quiz number one. And then I'll have to give you guys an access code. And then you have 15 minutes to take the quiz. It's 10 minutes, 10 questions, I mean. When you're finished with the quiz, I'm going to ask you guys just to turn your cameras off. As soon as everybody's done, we're going to resume class, so don't go too far. This won't be like your break or anything. But that just kind of helps me know who still needs to test and who doesn't. Okay.
Okay.
Wait, so 'cause I have my laptop in front of me. You want me to just get on cameras on my phone? Because I have my phone here that I'm on, and then I got my laptop. So you just want it on just one device?
You're okay as long as I can see you in the Zoom.
Oh,
Oh, okay.
Yeah,
Okay.
as long as you're in the Zoom and I can see,
I
and
think you can like split your screen, like you can split it and like do the quiz.
Oh, okay. Let me try to do that then.
you said we go in under modules.
yep, you should go under your module number two, and then your quiz number one should be under your module.
Okay. No big calculation. Okay.
It appears locked.
Okay, let me go in and check.
How would I?
Will someone in my class share their screen with me so I can see what the quiz looks like from your guys' end?
I can if you can walk me through how to start sharing my screen.
So you should be able to go down to where it says more on your Zoom. Hit sh
Okay.
hit share.
It says settings, stop video, stop incoming video, reset to default or whiteboard.
Hmm. Let's see. Are you on your camera or your computer?
I'm on my, oh,
I
Oh,
think I did it.
okay. January 14th. Oh, I see. Okay. Yeah, let me change something really quick so that you guys can get into it.
We have to screen share?
No, I just was wanting to see what the quiz looked like from your guys' point of view.
Oh, okay.
Not Dr. Zeller's class, you should not have to do that. All right. Are you able to see the quiz now? Is it unlocked for you in my section?
Mine says take quiz, but I don't want to press it and then like it starts because I don't know if there's an access code.
Yeah.
Mine says take the quiz.
Perfect. All right. We're unlocked. We're ready to roll. So if everyone will make sure you're visible in your screen, please. We're going to get this quiz started. Dr. Zeller's section, you have the same access code as my section, so we'll just all start it at the same time. And like I said, if you guys would please just turn your screens off when you're done with your quiz, that way I know everyone is finished, okay? Like I said, we have 15 minutes for the quiz. Do your best, okay? This is stuff from week 1 and some stuff that we're going to be covering this week, okay? Um, So whenever everyone is on screen, we're going to get started.
Can we start now?
I'm just
No.
waiting to I'm giving CJ one more minute to come on his screen.
Okay, perfect. Thank you.
Yep. There we are. Okay. So everybody, if you're ready, the access code is going to be capital O, capital B.
Hold on.
It didn't work for me. Just capital O and B.
Just capital O and B. Yep, OB.
Got it. Thank you.
Mhm. All right, I think everyone's finished with the quiz, so if everyone could turn their screens on, we'll go ahead and get class started. All right, welcome everyone. So for those of you who are coming from Dr. Zeller's class, officially, I'm Professor Young. Nice to meet you all. I teach this section, then I also teach a section on Wednesday evenings. I teach the 5:30 p.m. section. So I'm in class from now until like 8 o'clock, 8:30 my time. I'm currently in Ohio, so I might be not on the same time zone as some of you. But I'm happy to have you guys here. Welcome. So if everyone is in their Zoom and then pull up your chat, you should see that I sent you guys a PDF. Is everyone able to find that? This doesn't really pertain much to the students in my class because you guys already have access to this document. I'm talking mostly for Dr. Zeller's class, just so you guys have a little bit easier of a time following along with us in class today. It should just be a PDF, really, for you. We are going to use that here probably in the next 15 minutes. That is what we're going to be going over and reviewing today in class. So if you guys want that to take notes on, if you want it to follow along with the PowerPoint presentation that we're going to be going through, please feel free to download that and use that. Dr. Zeller might format her class differently than I do. We all teach differently, but we all teach the same material. So if you have questions, please like either chat in the Zoom or just ask me, okay? I want to go through Canvas really quick and show you guys where to find your assignments for this week, go over what we're going to be what is going to be due, and then kind of talk about next week because this course moves pretty quick. So I want us to all make sure we're on the same page. So let me pull up Canvas here. All right, is everyone able to see my screen? Awesome. So I'm in student view, so this is going to be how your guys' announcements are going to look. Some things that I wanted to point out to you that I didn't necessarily point out last week. Whenever you guys are wanting, because I had a lot of students reach out after the OB math assignment. If you guys are wanting extra practice in your announcements here, if you go into math, all of these videos and all of these resources and practice is available to you to use as practice. Okay. So if you guys didn't do as well on the OB math calculations as you would have hoped, this is a really good place to come if you guys want additional practice problems. Okay. Especially when we get into like talking about Pitocin and magnesium and heparin. And I mean, you guys have probably already seen like a heparin nomogram and how to work that out, but this will be really good review for you moving forward with the calculations. Okay. This week, you have your first sim chart that's due. Let's see, I'm going to go in your module. So you have your sim chart intimate partner violence that will be due by Sunday. Okay. Um, If you guys are having a difficult time finding your sim chart, please reach out to your instructor. We can walk you through it. If you guys are needing more instruction on like how to complete the assignment, how to submit it, things to do, things not to do, if you come into assignment expectations and resources, this announcement that's already loaded into your shells, it should be, and everybody should have access to this. Dr. Roberts, another professor who teaches at Fortis, she made this SimChart tutorial video for you. And that is a really awesome resource for you guys to refer to when you're completing your SimChart. Okay. The SimCharts, like we talked about last week, you only have one attempt on them. So take your time. Okay, you're allowed to use your resources. You can use whatever you need to use to complete the assignment, but take your time on it because these sim charts are 10% of your grade. So they definitely do make a difference towards the end of the semester. Okay, awesome. So let's go back into our assignments for this week because I want to just go over that before we get started into class. You guys also have discussion number 1 that is due this week for you. So your initial post needs to be done by tonight at midnight. Okay. This is to receive full credit. If you guys post after tonight, your initial post, well, you'll still get credit. We just have to remove that 10% policy, okay, penalty for the late submission. So make sure you have that initial post in today by this evening. And then on a separate day, you need to respond to 2 of your peers. And those responses need to be submitted by Sunday. Okay? Does everyone know where to find all of this stuff? Anyone have any trouble finding their assignments? Cool. So I'm not sure how it went for Dr. Zeller, your guys's her class, but for my class, I know for the OB math, the number 1 problem that we missed was question number 5. I'm going to share my screen again here and pull that problem up, and we're going to go through it together because it actually is just a matter of knowing your conversions, which in nursing, like in everything, like just sometimes the silliest, simplest things are what get us caught up, right? So let me pull up that problem and we're going to kind of walk through that together. If there is another problem that you guys want me to review, we can. I did not intend on spending like the entire, like a long amount of time going through every single problem. But we are definitely going to go through number 5 because that was the one that most people missed in my class. Okay, so let's get this pulled up. All right, so a nurse is tallying the total 8-hour shift intake of a patient who's been admitted with hyperemesis gravidarum. The patient has had the following: 8 ounces of ginger tea, 12 ounces of chicken broth, 2 8-ounce cups of lemon lime soda, and normal saline infusing at 150 mLs an hour. The patient's total intake is what? How many liters? Round to the nearest tenth. Okay, so we're basically in this problem needing to convert every single thing here to liters, right? So what would your conversion be for the 8 ounces of ginger tea? Can someone kind of walk me through that?
It's gonna be 8 times 30, if I'm not mistaken.
So that would be like, it's easier
Um,
sometimes to convert it first to mLs, right?
240. Yeah, so it's gonna be like 240 milliliters or something like that.
Yep, 240 milliliters, correct. So then, what about your 12 ounces of chicken broth? We're doing basically the same conversion because it's easier to go from milliliters to liters at the end. So sometimes it's easier to just convert these ounces to mLs and then at the end go to liters. So what would our 12 ounces of chicken broth be?
360.
Yep, so our 12
360.
ounces is going to be 360. You guys got it. So then our 2 8-ounce cups of lemon lime soda, so 16 ounces, what's that going to be?
480.
Yep, 480 mLs. So what we're going to need to do here is times all of this here by your total amount of hours, which is your normal saline. So your normal saline is going in at 150 mLs an hour. Times it by 8 hours is 1200 mLs. And then you're converting from mLs to liters. So that is your conversion here, which would give you a total of 2.3 liters. Okay. I think a lot of you are trying to go from directly from ounces to liters, and I think that's where it was confusing you. Because I was reviewing some of the submissions for the homework assignments, and it looked like a lot of you were just trying to jump just from ounces straight to liters. So I think that was where a lot of us were getting confused. So start with the smaller conversions and then kind of take it in by step. Does that make sense to everybody? Seeing it kind of written out like this?
Mhm.
Like now would be the time to say something. Like Jesus.
All right. So I think as long as everyone is okay with that, we're going to move on here. Did anybody else have any questions over a specific math problem that we could work through really quickly? If not, we're going to get into that PowerPoint I sent you guys.
It might have been one that I saw, but I would need to look at the paper to be able to run through it.
Okay. Um, for my class, and I'm sure for Dr. Zeller's class, if you guys, I graded your guys' OB math assignments. So you should be able to go into that assignment, and I made comments on your post. And I put in like how to work through each problem and which ones you missed. Question number 6 on our math had a typo, which I'm not sure if Dr. Zeller's class, if she mentioned this to you guys or not. But because of that, if you got that correct, I gave you a point back on your math calculations assignment, which actually pertained to a lot of you. A lot of you guys got it correct, and it was just marked wrong because there was a typo in our Canvas. So you got that point back. That's awesome. But go through your submissions. If you missed a couple questions, look through the problems that I wrote out for you. And if you're still confused on something, please reach out to me and we can meet and go through the math together. Okay. But also, like using those resources on Canvas to look through extra practice problems and stuff, those are going to be, that's going to be really helpful and beneficial. All right. Any questions on math before we move on? Speak now or forever hold your peace.
Okay.
Wonderful. So for Dr. Zeller's class, go ahead and pull that PDF up that I showed you guys. For my class, you should be pulling up the PowerPoint that was attached to your Welcome to Week 2 announcement. And we're going to get started going through that together. For my class, was everybody able to access my recorded lecture? Yep.
Yes.
Wonderful. Okay. So that announcement that I sent out on Saturday or Sunday, that is what the rest of your guys' announcements for the term are going to look like. There's going to be that recording that I posted, and then another PowerPoint that we're going to be going through during class, and then your assignments that are due for that week. Okay. So definitely make sure on your own time that you're watching those recorded PowerPoints. That's going to benefit you for just getting the material because there's a lot of material that we cover in this class. What we're going to go through during class itself is just some like highlights, some really big important things that I want you guys really to focus on when we're studying for our exams and our quizzes. And then aside from that, watching the recorded lectures is going to help you as well when we're studying for our tests. All right, so let me share this PowerPoint. If everyone wants to have theirs up to take notes on it, that would be awesome. This one is not going to look exactly like the one that you guys have from my announcement, but it's very similar. So let me get this fixed here on my screen. There we go. Okay. Alrighty. So we're going to go over some review from last week's PowerPoint. This class is going to also go by a lot faster if you guys are interacting and also answering some of these questions that I have for you. Okay. So a nurse is providing teaching to a woman about the fallopian tubes and fertilization. The nurse knows the teaching was effective if the client states what. So what is important for us to know about the anatomy of the fallopian tubes and where does and fertilization itself?
Doesn't fertilization happen in the fallopian tubes?
Correct. Yep. So the fallopian tubes are the passage between your ovaries and your uterus. That's where that ovum travels through, and it's where fertilization takes place. You guys will definitely want to know that about where fertilization is taking place. Okay. This was something that we need to know. What happens if you have a zygote implant in the fallopian tube? You have an implant there. What would that be called?
An ectopic pregnancy.
Yep. And where should it be implanting if we don't want it there?
Uterus.
Endometrium.
hmm So we have, if that implants in the fallopian tube, that is an ectopic pregnancy. We go into a lot more detail about ectopic pregnancies later in the course. What we need to know about those, though, is they are an OB emergency because you run the risk of that fallopian tube rupturing, and then we run the risk of hemorrhaging. So that is a big deal. Usually, people that come in for an ectopic pregnancy, what ends up happening is they have to get the pregnancy dissolved. So it depends on like the stage of how like how many weeks what their gestation is, okay? If they're early, before usually like 6 or 7 weeks, we can give them a medication to dissolve the pregnancy. If they are past that point and that pregnancy has started to develop and has progressed and it's bigger, they're going to need a surgery to remove that. Okay, so ectopic pregnancies, we would consider those to be an emergency. The biggest risk of ectopic pregnancy would be a hemorrhage, and we want our implantation to occur in the endometrium in the uterus. What are some comorbidities that can contribute to a high-risk pregnancy, which would increase maternal and neonatal morbidity and mortality?
High blood pressure, diabetes.
Obesity.
Mm-hmm.
Being an adolescent.
Yeah, adolescent pregnancies can be considered high risk for sure.
Being over 35.
Yeah, which I hate the term, but they call that a geriatric pregnancy, which I think is just, we don't want to hear that when we're, over 35, but so yeah. So some big ones. Hypertension. I want you guys to know that that is probably one of the biggest comorbidities that you can have in a pregnancy. Having high blood pressure in a pregnancy is probably the highest risk pregnancy if we had to classify it and give it, you know, a scale. This is because high blood pressure affects the development of the placenta, which ultimately affects the oxygenation of our fetus, right? We talked about that a little bit whenever we were talking about anatomy last week. If you have high blood pressure and your vessels are constricted, that's going to reduce the amount of blood flow that's getting down to that placenta. And blood flow to the placenta ultimately means oxygenation for our baby. So your blood pressure is really having controlled blood pressure is a huge, huge thing for our pregnancies. Diabetes is another big one. Diabetes leads to a whole nother slew of problems with not only moms, but with babies and how they develop. So one of the biggest things we see with diabetic moms is we see macrosomic infants, which that just means a really, really big baby. Okay, this is all kind of going ahead. So what I want you guys really to focus on is these things, but I'm trying to put these extra little tidbits in just to kind of help tie together information you guys should be learning later in the class. So diabetic moms, we worry about really big babies. If you have a really big baby, a thing that we worry about during labor is something called a shoulder dystocia, which is another OB emergency. Those big babies can sometimes get stuck coming down through the vaginal canal. Their shoulder gets stuck underneath the mom's pelvic bone. And that can lead to clavicle fractures and can lead to brachial plexus injuries. There's a whole other bunch of stuff that can happen with shoulder dystocias. Moms can hemorrhage because that big baby and the tears, if they're having tears. So those are big important things. Obesity is another one with high risk as to contribute to a high risk pregnancy. Typically, obesity has you at a higher risk for developing hypertension and diabetes in your pregnancy. Okay, so that's why we list that there. What patient populations have a higher overall rate of maternal morbidity and mortality?
African Americans.
Yes. African Americans definitely are a patient population that are at a higher risk. The other ones that we have listed here would be American Indians and Alaskan Natives. They talk about this a lot more in detail in your textbooks in this chapter. I didn't really highlight it too intently during class last week. It was in my PowerPoint slides, but they go into it in a lot more detail um, on your texts, in your text. What are the three phases in the cycle of violence? My class, this is kind of, I didn't have it on my slides, so this is in your textbooks. We'll go through 'em. So the first is the honeymoon phase, right? Where everything is all good and dandy. Everybody's happy. They're very much in love, affectionate. Tension building phase, like some fights and start to happen. They're at odds. The stress levels increase, and then the abuse. Okay, and then it starts over. That's usually the cycle that we're seeing. Last week we did talk a lot about abuse, domestic violence, human trafficking. Those are things that we need to know for exam number one. We also talked a lot about how oftentimes, if abuse is occurring in a relationship prior to a pregnancy, it can increase and worsen during a pregnancy just because of the stress that is placed on the couple during the pregnancy, feelings of jealousy potentially from the partner for the developing fetus or for the pregnancy itself. So if we have a patient who comes in and we notice those signs of abuse that we talked about last week, we need to try and get them without their partner so we can question them and talk to them about like, hey, what's going on? Like, can help you form a plan, and all that good stuff. Can anyone tell me some signs or things that we can look for as nurses that could indicate that our patient is experiencing abuse or is a victim of human trafficking?
Maybe
Um,
having the partner answer all the questions.
Yes, that's a great one.
yeah, look,
Their attitude, the way they eye contact.
Yes, definitely.
They won't leave him alone.
Yeah, they're not going to leave that room for sure.
that pretty much is just of it. You be looking at their clothes, their demeanor, the eye contact, if they speak and how they speak. If they always look at the other person before they answer, they kind of be, looking for cues of I should or should not say such things. In terms, they may be even overly protective of their abuser. Don't ask them, don't bother them. I don't want them to get upset type deal. So you kind of just gotta look for the puzzle pieces. They'll be subtle, but they'll be there. Unnecessary or overly use of makeup sometimes could be a thing that they use to try to cover it up, especially on the wrists. You want to cover being grabbed and stuff like that.
Definitely. No, that's excellent.
Also, like signs of neglect, like maybe dirty clothes or like just like not looking um clean enough.
You're
Yeah,
right, yeah.
definitely. Yeah, all those things that you guys mentioned, that's perfect. Yep, those are things that we would notice or try to notice as bedside nurses. As the bedside nurse, we want to try and ask these patients yes and no questions. Okay, we're going to try our best to try and build trust with this patient. If you're immediately walking in the room and you're like, your partner, you need to get out of here, like immediately, okay, that patient is going to close up because they're going to feel the backlash of our action. So it needs to be a little bit more subtle. It needs to be a little bit more planned than that. Oh, we have to take her back for a routine examination that no one else is able to be in the room because we're using x-ray, whatever it may be. Okay. These things we can arrange in a hospital setting. It's a little bit harder in a doctor's office, right? Because you don't really have anywhere else to go with the patient besides the bathroom, and you're not going to go to the bathroom with this patient. That's just not realistic. So we got to get a little creative, but the most important thing is we want to establish trust with these patients. We want them to feel like they can open up and talk to us. What are two screening tools for women's health a nurse can educate a woman about? Like
Prenatal.
typical testing.
You said for typical testing, like in terms of like doing a self physical thing like that. Is that what
Yeah,
you mean?
yeah. Yeah. Specifically, most towards like women's health. when we're
Okay.
thinking just what like a woman would get an exam for that potentially a man wouldn't, you know?
Yeah,
A
she'd be
pap
checking.
smear.
Yeah, she'd be doing a self-breast exam.
Hmm.
Um, looking for any abnormalities, like if they do tanning, so you want to make sure you don't have a new mole or a new spot that just kind of popped out. Basically, just keep an eye on your skin or what's going on. You're going to educate them on their diet,
Yep.
um,
Hmm.
and on the lifestyle they're living in terms of, what could be hindering them from reaching whatever goal they're trying to reach.
Yeah.
Um, Typically, a lot of people look forward to support groups of some sort. Nobody kind of wants to go at it alone or feel like they're the only one with that problem. So usually when you have someone willing to kind of walk with you, so education on support groups and how we can get this going.
That's great. Yeah. Some other ones that we do. So you hit it on the breast exam for sure. And then our pap test, that's going to screen for cervical cancer too. But yeah, all those things that you mentioned are great. We do need to provide some thorough education to our patients, specifically women who are coming through and navigating pregnancy or breast cancer or whatever it may be alone. We need to give them support groups and different resources for that. That is huge. um, our pap tests, typically, like with a pregnancy, they can do a pap screen at the beginning of the pregnancy whenever they swab for other type of STDs like chlamydia, gonorrhea, or whatever. But if you're up to date on a pap, they don't do that just automatically if you're whenever you're pregnant. So the pap tests with pregnancy don't change. It just is routine, whatever that routine is.
I have a question.
Yeah.
Is it accurate that they've kind of started to request that women do less of their self breast exams because it's getting a lot of false, what I'm saying? I felt something abnormal, so they're running a lot of unnecessary tests, I guess, if you look at it that way.
Yeah.
Um, it's kind of women are kind of scaring themselves in a sense, which is it's rightfully so. That's something that wasn't there and now it is. So, what do you think is going to be the next step with it? Like, do it less often or deeper teaching
Um,
on what it may actually feel like? Because that's kind of hard to, describe to someone.
So, yeah, you're spot on. There is now a bunch of literature and just like doctor recommendation now that like women shouldn't be performing breast exams as frequently. Typically, they're wanting you to try and do that on an annual basis. But the thing with breast tissue is a lot of things can alter the density of breast tissue. One of the biggest things is caffeine intake. So if a woman like drinks a lot of caffeine or something, they have more dense breast tissue. And density in your breast tissue can sometimes palpate similarly to um, tumors, benign lumps, things like that. So yeah, they are recommending that women perform less self breast exams. They're asking too, like if you have an annual exam with a primary care physician, allow them to do the palpation of your breast tissue. Um, because exactly like you said, CJ, they're having a lot of instances where these women end up getting biopsied and they end up going and getting like invasive diagnostic testing done that isn't necessary because they just are feeling typical normal alterations in their breast exams. It's kind of similar to like a colonoscopy, right? The colonoscopy ages are changing, so they're recommending people get them younger and younger. With mammograms, if you have a family history, they're recommending you get mammograms sooner, but we're not relying on self exams as much for breast tissue. That's a great question. Um, so how can a nurse ensure that she's meeting the standard of care? As a nurse, like what do we care about in nursing? Like what is something that we really want to make sure that we're doing, that we're following specifically?
Uh,
Helping to prevent um a condition or something.
Mm-hmm. Prevention. So like what's the biggest thing as
safe,
a nurse you can
safe nursing care practices, like
Mm-hmm.
uh, sticking to God, what's the word I want? I can't think of the word I want to use, but
Like
that's how we
evidence-based.
know we're giving competent care, in a sense.
Yes. I heard someone too say evidence-based. So evidence-based
Yeah,
practice.
evidence-based practice.
Yes, exactly. So, as nurses, it's important we stay up to date with our evidence-based care, evidence-based practice, right? If there's a new standard of care for inserting a Foley catheter, we usually receive in services about it in the hospital. And then it's important that you're following that standard of procedure when you're doing bedside care. Um, we want to prevent neglect, right? Which is any type of action that a nurse does or does not perform that does not meet or falls underneath that standard of care. Okay. Neglect is the biggest thing that I want you guys to really know and understand when going and studying for your quiz and your exams. Um, the other thing with standard of care is the biggest thing for us as bedside nurses. One of the things that is drilled into your brains and it will be continued to is preventing med error. So we're the ones at the bedside, we're administering those drugs. So we need to know our 5 rights of medication administration, which you guys, I hope know all of those. Um, so that is going to be the biggest way that we can prevent incidents or things like on our end that we can really ensure we're doing correctly. So here, this is kind of an umbrella for the what we talked about. So utilizing policies and procedures from the facility. So obviously, your policy in your nursing facility is going to take precedence over most things. But evidence-based practice, reducing med error, um, and just performing good care as bedside nurse are some things that we can do.
I
Okay.
have a question.
Yeah, what's up?
Um, for our quiz, if we miss anything, do we ever know like what it is that we missed?
So if you want to review your quiz, you can meet with me and we'll go through it together. But I don't think you guys ever really get access to the questions that you did or did not get wrong, right or wrong. If you meet with me, we can talk through it and I can kind of go through them with you, but you typically know we don't release those questions and answers.
Gotcha. Thank you.
Yeah. So, who here is super confused with GTPAL? Hopefully no one, but it happens. This was something that a lot of students last term had a hard time with. So, GTPAL, it was in your other PowerPoint that I sent you guys that you guys should have access to right now. We went through it a little bit more in depth. For this slide, we are kind of just breaking it down for you. So your G stands for gravidity, which is the number of pregnancies total that a woman has had. Okay. P stands for parity, which is the number of deliveries after 20 weeks. Okay. So if I'm a nurse that works bedside on OB and I'm getting a report and I have a mom who comes in and this is her 4th pregnancy and she has 3 living children at home, in report, typically the only thing they talk about is gravidity and parity. Okay. So I'm going to get a report that says this mom's a G4P3. That means this is her 4th pregnancy. She has 3 babies that are living at home right now. That does not go down into all the GTPAL. It doesn't break it down that far. It is just number of pregnancies, number of deliveries after 20 weeks. Okay. For physician offices, for OB offices, they split it and break it down into all of these subcategories, which is why we want to know them. So your G is your gravida, the number of pregnancies. Your T stands for term deliveries. So that's any baby that's born after 37 weeks of gestation. Your P stands for preterm, which is any baby that's born between 20 weeks and 36 weeks and 6 days of gestation. A stands for abortions, and that is anything less than 20 weeks. That can be medical abortion, that can be elective abortion. It doesn't matter. They don't split it or anything like that. Just any abortion earlier than 20 weeks. And then L is your living. Okay.
I have a question.
Yeah,
How does abortions fall under that umbrella of parity if it's under 20 weeks and parity is over?
that is a good question. Um, we can just pretend it's not under there because it shouldn't. Yeah, you don't really have a parity of an abortion. So what it would be if I had, let me see. So if you had a mom who came in and this is her 2nd pregnancy and she doesn't have any living children at home and we're splitting it into just your G's and P's, it would be a G2P0. Okay, so that's the only difference with that. So your abortions would not fall under this umbrella. Your abortions would not count as an actual, like, as a living infant at home if you're just doing your G's and P's. I think it's under this umbrella in this picture because they're just going through the entire mnemonic. But yeah, so for that, all it would count towards is a pregnancy. It wouldn't count towards a living child after 20 weeks. Does that help? Awesome. Okay.
Another question with the abortion, that's like including like planned and like unplanned, so like miscarriages, right?
Yes. Mm-hmm. Yep.
Like double check.
So yeah, a miscarriage, an ectopic pregnancy, that would all fall under the umbrella of abortion. Yep.
Thank you.
Yeah. So all right, let's practice. So a client on postpartum just delivered a son at 37 weeks. Is that a term delivery at 37 weeks?
Yes.
Yep. She has a daughter at home that was born at 28 weeks and a son that was born at 38 weeks. What would her GTPAL be? So how many pregnancies total has she had? That's your G.
3.
2.
She's had 3 because
Oh, 3.
we do count the one that she just delivered in this. Yep. How many term deliveries has she had?
2.
Yep. How many preterm deliveries has she had?
1.
Yep. How many abortions?
0.
And how many living?
3.
So we're a G3, we're a term 2, we're a preterm 1, we're a 0 abortion, and now we're a 3 living. If she was in labor and she hadn't delivered, what would change?
The G.
The living.
The living. She would be a G3, T2, P1, A0, L2.
Mm.
So you saying that being in delivery will be a living?
So whenever that baby is born, yep, they're considered a living child then. Once they take their first breath of oxygen and we've given them a birthday and a time, they would be considered a living child at that point.
Oh,
If
I
there's,
thought you said in delivery.
I
Like
think
she
I'm
said,
misunderstanding you, but um, yeah, any time that we're still in utero, like that baby has not been born yet, that is only going to count towards your total number of pregnancies, not your living children yet.
okay,
Yep.
gotcha.
Yep. And then everybody, you guys all understand the difference between the preterm and the term delivery and why that would fall under that category, right? You have a 28-week delivery, which would be fall before that 37-week time frame. Awesome. So this one, a pregnant multipara has a son who was born at 35 weeks. Would that be a term or a preterm delivery? So is that
That's a
before
It's
preterm.
35?
preterm, right? 20 to
Preterm.
36 or 20 to 37.
So it would be preterm. So 20 to 37 weeks would
I got
be your
36.
preterm baby. A set of identical daughters who were born at 36 weeks. So that's twins. So twins, we get a little bit fancy.
Now,
One preterm.
they still would sit in preterm if they're twins.
That will be one gravid, like it will count by one pregnancy, no?
That would be one pregnancy, correct? But it's
Like,
2 babies. So when we're counting them in the GTPAL, the G would only count the pregnancy and then the as one, and then the babies would be independent as different babies. But those are both preterm, right?
Mm-hmm.
And then the client also delivered a stillborn 2 years ago at 38 weeks. So that baby was stillborn, so that baby is no longer living, right?
that falls under A.
So that wouldn't fall under A because we are over that 20 weeks.
Okay.
That would technically be a term delivery, right? Because we're over that 37-week period, but it would not be considered a living child.
But the gravida would still be, in this case, 3.
Yes.
Okay.
So the set of identical twins, born at 36 weeks will be preterm 1 or yeah, 1. Right? 1.
Let me pull it up and we'll walk it through.
Because I think you were saying even though it's pregnancy with twins, it's still one pregnancy.
So it
Yes.
would be actually 1,
Yeah.
4, 5. So those pregnancies would be separate. So it would be considered a 2 pregnancy. So let me break this down because I think I got us a little confused here. So a pregnant multipara, which multipara is just a fancy word meaning she's been pregnant multiple times, has a son who is born at 35 weeks. So that is a preterm delivery. So
Right.
that's one of these.
Mhm.
A set of identical daughters who are born at 36 weeks. So we have twins. So that does, I got it backwards. So that counts as 2 in your G's and only 1 in your P as a preterm delivery because they delivered at the same time. So that's only considered 1 delivery.
So it's pretty much saying pregnant of 2.
Yeah. Mm-hmm.
That's it. Yeah.
Yep, you got it. So then the client also delivered a stillborn 2 years ago at 38 weeks. So that was another term delivery. And then had a spontaneous abortion 7 months ago. So then this is the A for that abortion.
3, 4, and 5. Okay, so
All
let's.
right. I can do it. I would just have to read it like 4 or 5 times and then be like, okay, makes sense.
So let's go through this again because I had flipped them at the beginning. But whenever you have twins, the pregnancy is going to count as 2 G's because
I got
you're pregnant with 2 babies.
Mm-hmm.
But when you do the delivery, you only have to have a delivery 1 time, right? So that's only going to count towards your other section as 1. So for the
But if the twins count as 2, wouldn't that be 6? Because she's currently pregnant. She has a son.
Yeah, it
That's
doesn't.
2.
It's
Then there's
1.
the identical daughters would count as 1 because
Oh yeah,
then
you're
she
right.
still
Yeah,
has
nope, you're right.
the
You're
stillborn and the yeah.
yeah, because I forgot that she was pregnant. Sorry, everyone. So your pregnancy that she currently has is your first one. Your son who was born at 35 weeks is your second pregnancy. Your pregnancy of your twins is your third pregnancy. Your stillborn would be your fourth pregnancy, and then your abortion would be your fifth pregnancy. Okay, that was why I was confused because I was like, I'm pretty sure we had it right the first time. So yeah, you're 5 because she's currently pregnant. So your twins, I take it back. I'm so sorry. Your twins are going to count as only 1 pregnancy and 1 delivery, but then it's going to count as living 2 separate living babies.
Gotcha.
So pregnant with twins will be count of as 1.
Yes. Mm-hmm.
Okay. Grab it a 1.
Yep. So then then your delivery would be 1 as well.
Either
Whatever
term or
that is.
preterm will be 1. But
Mm-hmm.
on living will be 2. Except let's say in the case one of them is like dies, will be 1 aborted and 1 living.
Yes. Mm-hmm. Or 1
Okay.
wherever like preterm or if it was term delivery, you know what I'm saying?
So when we get to living, we don't count this pregnant child though, right? Because
Right. Because she's
again,
currently
hasn't taken the first breath, hasn't been pushed out.
right.
So we would all right, we're only counting that baby as a part of the number of pregnancies.
Correct.
To
You
get,
got it.
okay, I got you.
Yep. All right. So with twins,
I have
let's
a
wrap it
quick
up. Let's
question.
finish on a
Sorry.
strong. Sorry, what was that?
No, I have a quick question. So when you're pregnant, that falls under gravida,
Yes.
or it does? Because
Yes.
isn't gravida when it ends before 20 weeks, or it just means pregnant, like you're just pregnant, and if it ends before 20 weeks?
It's just with gravida, it's just the amount of times you've total been pregnant, regardless of the outcome of the pregnancy.
Oh, got it. Okay, sorry. Thank you.
No, it's okay. Um, this is a hardest thing to kind of break down sometimes, but it's important for us to know because you guys will definitely have a question about this on your exam. So, we really want you to understand this. We have a couple extra practice problems at the end of this PowerPoint that we're going to go through that will help also. Um, but let's go through it one last time so that we all feel really good about it and we're all on the same page. So this lady is currently pregnant. So that counts as one of her pregnancies. She had that 35-week son who was born. So that is your second pregnancy. Your identical daughters, your twins, that would be your third pregnancy. That stillborn is going to be your fourth, and then that a spontaneous abortion is going to be her fifth pregnancy.
Correct.
So, and then when we get down to our T's, we had one term delivery, which would be our 38-week
Yes.
here, regardless that the baby is currently living or not, right? That was our term delivery. We have two preterm deliveries. That would be your 35-week baby here, and that would be your 36-week twins. And those twins only count as your one delivery. We have one spontaneous abortion, which is this here, that 7-month abortion, that one that happened 7 months ago. And then we have three living babies because we have that son who was born at 35 weeks, and we have those two daughters, the two twin girls. Everyone feel good about that. I'm sorry I got us so confused at the beginning, but I feel like we made a comeback.
I'm still smarter than the fifth grader. We can do it. Good go.
Awesome. So we, like I said, we are going to want to know this pretty well. So definitely understand with your GTPLs what this all means. Okay, we're going to do one last one here. So a multigravida delivered a daughter at 28 weeks and had two spontaneous abortions at 12 and 14 weeks. Is this client a primipara, and what is her GTPAL? So let's run through our GTPAL together. How many times has this woman been pregnant?
Three.
Three.
Yep, three. So she had a pregnancy and that she delivered at 28 weeks, and then she had two abortions, which are, like we said, our abortions still count as a pregnancy. She had two of those, so she's been pregnant 3 times. How many term deliveries has she had?
0.
Yeah. Correct. How many preterm deliveries?
1.
1,
How many abortions?
2.
2,
And then how many living children?
1.
1.
Yep. Yep. Does that make sense to you guys?
Mhm.
What is the primipara?
It's a great question. What is a primipara?
First time giving birth.
First, yeah.
Yes.
Like she's only given one preemie birth,
So
or
she's
just
been
like
pregnant. So she's been pregnant. She's been pregnant
Has
three
one kid.
times. She only gave birth once.
Yes, but she's already given birth once, right?
But the abortions doesn't count as like preterms because she had it at 12 and 14 weeks.
Hold on, let
They
me go
weren't
back.
born. It's
So
got to be through the labor process, I guess.
anything earlier than 20 weeks, we would just consider in an abortion. Okay, which is a separate category. Primipara is really referring to a woman who's given birth to any infant over 20 weeks of gestation. Multigravida, whenever we're talking about gravida, right? So let's think about it in the terms of our G's and P's. This might help us. So when we're talking about G, and we see it here, that word, gravida, that's referring to the total number of pregnancies, right? So if we see multigravida, that means that she's been pregnant multiple times. When we look at para, that can also refer to our P as in parity, which parity would mean living children, the amount of times that she's given birth and has a living child. So a primipara would be somebody who has not given birth to a living child yet. A multipara would be somebody who has multiple children living at home. A primigravida would be someone who's pregnant for the first time. Multigravida is somebody who's been pregnant multiple times. Can you guys kind of see the correlation there between our gravity or parity and then our multigravida, primiparida, that kind of stuff?
Hang on, I want to make sure I get that right. So primipara, first time giving birth,
Yep.
and then the multipara. I'm assuming that's what's next.
A multipara would be somebody who's given birth multiple times, yep, to a living child. Um, so then our multigravida would just mean that she's been pregnant multiple times. If it's at a primigravida, that means it's her first pregnancy. So these terms are definitely things you guys are going to want to know. But the other thing I will tell you is in this case, if it's asking, ignore that. Let's pretend it didn't ask us if she's a preemie para. If it's asking her what is her GTPAL, I don't want this word here to confuse you guys because that is not telling you a pregnancy, right? That's just how we would classify this mom. So that's kind of when you're answering your questions, you're reading through your exam. That's something that we want to know. So, sorry, one second. And CJ, I'll look through this, what you sent me here really
I
quick.
just didn't want to post it and I missed something. Like I was trying to give them the short
Oh,
piece
that's
of
all
that
right.
already, so they don't have to do it.
Yep.
I mean,
Yep.
there's a zero in there, but you get the point.
Yeah, that's right.
All right, I'll take care of it.
But yep, so when you guys are answering these questions, definitely focus on if it's a GTPAL question, we don't really need to focus on if they're calling them a preemie-para, multi-para, multigravida, preemie-para. You know, that terminology is sometimes slid in there to confuse you. So we want, when we're talking about PAL, just to work on the pregnancies. Okay? Any other questions about this? Does everyone feel okay about it? Maybe not like awesome yet, but we're going to need to practice a little more, but we got the basics down. Okay. All right. Moving on here. So we have Abby. She is 17 years old and she comes into the prenatal clinic. What symptoms could Abby be experiencing that would cause her to think that she could be pregnant? What are some things that women could experience that they may be like, I might be pregnant?
Nausea, vomiting, tired all the time, missed period.
This
Like
period.
sensitive breasts.
Mhm.
Yep, breath sensitive. Food don't taste the same, maybe.
Yeah. Let's see. Another big one is she's missed her period, right? If somebody has a missed period, they are going to say like, "Oh, I'm pregnant," immediately right off the bat. Breast changes and tenderness, that's a big one. So like we talked about last week with our anatomy, in or this week in anatomy with pregnancy, your breast changes, the breasts are going to be bigger. They might ultimately have some colostrum that start leaking from them. They're going to be super tender and sensitive. So that is something that a woman could experience and cause her to think that she might be having a pregnancy. Nausea and vomiting is huge. So that can be something that women will experience that might make them think they're pregnant. Urinary frequency and fatigue, those are all big ones. What type of pregnancy signs are these? If we're talking about dividing them into the three categories that we had talked about, positive, presumptive.
Presumptive.
Probable.
Presumptive.
Presumpt.
So our presumptive signs of pregnancy, these are things that women can experience that may lead them to think they're pregnant, but that does not necessarily mean that we are pregnant. It is not a foolproof diagnosis, right? These are just symptoms, and um, these can all be occurring by something else, right? Like some women will miss a period because, let's say, they have PCOS, polycystic ovarian syndrome. If they have hypothyroidism, that can interfere with their periods and their cycles. Any extreme stress can alter a woman's cycle. Your nutritional status, your nutritional intake can change everything. Breast changes in tenderness, like that can be caused by a bunch of different things. So all of these things, we are considering them presumptive because it means that doesn't really mean that they're pregnant. It's just things that are common in pregnancy. Let's see what happens. Abby states that she has never been pregnant before. So if Abby is pregnant, would she be considered a nulla gravida, a primigravida, or a multigravida?
No, gravida.
She would be a primigravida.
Gravida.
If she is pregnant, because this would then be her first pregnancy, so she's pregnant now, currently. A nulla gravida would be somebody who has never had a pregnancy and they don't even suspect that they are pregnant and they aren't currently pregnant. Okay. Primigravida is somebody pregnant with their first baby, and multigravida is somebody pregnant with their subsequent pregnancies. Would she be considered a nullipara, a primipara, or a multipara? Think about what para means.
Nullipara.
Yep. Because a primipara would be somebody who has delivered.
Never been pregnant.
A nullipara is somebody who has never
Had a baby.
had a baby.
Period. Nulla gravida has never been pregnant.
Yep. What would her GTPAL be?
G1, T0, P0, A0, L0.
Excellent. You got it. G1, T0, P0, A0, L0. Does this make sense to everybody? When we're talking about primigravida and all of these up here, focus on what this back word means, gravida. Total number of pregnancies. Para over here, living children. If you think about it that way and you break it down that way, it becomes a lot easier. Okay. We're going to run through these different signs and symptoms, signs of pregnancy, and I want you guys to tell me if you think it's probable or positive. A positive pregnancy test, what is that?
Probable.
Probable. If we hear fetal heart tones.
Positive.
Positive.
Positive. Chadwick sign.
Positive.
That one would be probable. What is Chadwick sign?
It's like when like somewhere in your genitals like become bluish, no?
The cervix.
Yep. It's a bluish discoloration of the vagina and cervix. So this would be probable because like that can also be caused by a lot of different things. It can be, right? Not as common, but you know, we can't use that only as a, yep, you're definitely pregnant. Ballotment. Who knows what that means?
That's probable.
What is ballotment?
Is that
Like bloated?
No, not bloating.
it's like pushing against the uterine wall?
So it's a technique where our healthcare provider feels the fetus like in the amniotic fluid after like feeling the uterine wall, yep, indicating that there's a baby. So it's just a exam that a provider will do on the uterine wall to feel for a fetus, like for a fetal rebound in the amniotic fluid. So
So it be positive.
This is still probable. So let's think, what would our definition of positive sign of pregnancy be? Do you guys remember?
What did you ask?
What is our like definition of what a positive sign of pregnancy is? Like
A positive sign is anything that the baby gives you. So fetal heart tones, ultrasound, seeing the baby move, things like that. Anything that the baby gives you is going to be positive.
Also, like the HCG levels and the blood work rate.
That would be probable.
Yep. So the only thing when we're talking about positive, so this is going to help us. So the only thing that would indicate a positive sign of pregnancy is if we physically auscultate baby's heart rate or see them on a scan. So if we visualize a fetus in a uterine sac or amniotic sac, that would be a positive sign. If we hear them via a Doppler or any type of oscillatory method, that would be a positive sign. Anything else is just probable or presumptive. Okay?
I got it. I remembered it as presumptive is obviously it's the mom presuming. So she's telling you all of these things.
Mm-hmm.
Anything that the mom tells you that you can't physically measure is going to be presumptive. Anything that you can measure is going to be probable, and anything the baby gives you is going to be positive.
That's a good way to remember it. Yeah.
So it's like
Yeah,
subjective and
that's true.
objective.
I was about to say, CJ, like something like presumptive will be something subjective, such as like nausea and like well, like also the tenderness on the breast. Well, that can be also like something objective. But yeah,
Yeah.
Yeah, I
Yeah.
got you.
like any signs that like a mother can like experience.
Hmm. Yep. Any like symptoms, we're going to go with presumptive. Any type of testing that is associated with pregnancy but does not involve listening to a baby's heart rate or seeing them on a scan would be probable. So, like we have up here already, our HCG test, that is only probable because HCG can also be elevated and oftentimes by tumors. Ovarian tumors can raise HCG levels. You guys don't need to know this, but I found this out this year and it genuinely freaked me out. But if a woman accidentally consumes mouse droppings, she would have a positive HCG, which is really frightening to think about. But I had a provider who had a patient come in for a laparoscopic salpingectomy where she was removing her fallopian tubes, and she had a positive pregnancy test, and this lady was like 75. And she lives on a farm and stuff, and the provider put it together. But that can
He's
cause
just
HCGs to go
eating a
up.
lot of wow.
Yeah, so that's scary. You don't really need to know that. I would share that because it freaked me out. But so anything that is a test that we can run, or something that is typically associated with pregnancy, but it does not involve seeing a fetal heart rate or seeing a baby physically on a scan in a uterus would be probable. Anything that's presumptive would just be our signs and symptoms that we can experience, like the nausea and vomiting and all that. All right, ultrasound.
Positive
Positive. Yep, we're
most of
seeing.
the times.
Yeah, we are seeing that baby. We are going to visualize them in utero. So that is definitely a positive sign of pregnancy. Hagar's sign.
Probable.
Yeah. And what is it? Does anyone remember?
Okay, I'm reading that it's like a softening of the isthmus, and I guess it's like a digital exam.
Yep. Mm-hmm. Yep, you got it. So it's basically like whenever the lower part of the uterus or the cervix is softening. So it makes it feel a little bit different whenever you're doing a physical, like a exam. Like if you were to do a digital exam on a pregnant woman, it would just be like some softening and it would feel a little bit different. But that would be probable. Braxton Hicks contractions.
Probable.
Probable. Braxton Hicks contractions, like what we talked about, like those are the tightening, cramping feeling that women can get during a pregnancy. So if somebody comes into your office and she's like potentially pregnant and she tells you she's having Braxton Hicks contractions, that doesn't really apply until later in the pregnancy. It's mostly that would just be us defining it as cramping at that moment. So this is kind of a fancy way to just say this woman is experiencing some cramping, and that would just be probable. An X-ray.
Probable.
So
Positive.
this one would be positive. Why would that be positive?
You would be able to see it.
You'd be able to see the baby.
I thought you said
Uterine enlargement.
Probable.
Probable. Yep. Goodall's sign. This is similar with Hagar's sign. Goodall's sign is some softening as well, some softening of the lower portion of the cervix. So would that be probable or positive?
Probable.
This is going to be probable. We're not visualizing or hearing a baby. This is just another like physical examination that a provider would do for a pregnant patient. Fetal movement assessed by an examiner.
Positive.
Positive.
Yep. We're detecting fetal movement. We are feeling or seeing that baby move. That would be positive. If a mom says, I'm pregnant, I'm however many weeks, let's say she's 15, 16 weeks pregnant, but she hasn't had a diagnostic ultrasound, she hasn't had any, she hasn't heard the baby's heart rate on a monitor, and she says, but I feel the baby move. Would that be probable or would that be positive? Or would that be presumptive? Ooh.
Presumptive.
Presumptive.
Presumptive. Because there's also like psychological, like something psycho that is like something mental that is related to like a pregnancy, no?
I mean, sometimes women too, like, I mean, I'm not sure case by case, but yeah, neurologically, women go through a lot of changes during pregnancy. But if somebody has not had a diagnostic ultrasound, or they have not visualized the baby, or they haven't listened to the heart rate, and they say, I feel this baby moving, we can't use that as a, yep, you're definitely pregnant, right? That would just be the mom's presumptive sign of pregnancy, that she's feeling that quickening, right? Or that lightening that we talk about, which is those really, really early fetal movements. If she says that she's feeling that, we can't rely on that to say, yep, you're pregnant. We have to visualize or listen to see. Okay. Definitely know this stuff, guys. Okay. You will probably find some questions on this for sure. All right, Nagel's rule. Let's practice. First, how do we calculate? How do we use Nagel's rule? What is the formula?
You take the first day of the last menstrual period, you take 3 months off of it, and then add a year.
Yes.
Days.
It adds 7.
You add 7, yeah. So you add 7 days. So it's the first day of the last menstrual period. Add a year to it. Subtract 3 months, and then you add 7 days. Okay?
Oh, can you please repeat that?
Yeah. So you take the woman's first day of her last menstrual period, which if you see it written as LMP, that means last menstrual period. That's just the abbreviation, the abbreviated version.
Mm-hmm.
So you take that day, you add a year.
So 365.
Mm-hmm. And then you subtract 3 months.
Okay. In days or
Just like the month by month. So like July, subtract that by 3 months. What's 3 months before July?
okay.
And then you would add 7 days. All right, so
Okay.
Abby says, this is our patient Abby. She says that her LMP, or her last menstrual period, began or was July 2nd of 2023. So let's add our year, July 2nd of 2024. Let's subtract our 3 months,
May 2024.
May 2024.
4, and then let's add our 7 days.
Ninth.
May
May
9th, 2024.
April.
So it would be April, because we're going from April, May, June, and then beginning of July. So then it would be the 3 months past. So July 2nd, let me see.
Okay, I get it now.
So you're going not just based on you're going from the actual day. So
Oh, we
July
want the
2nd,
entire
back
day.
1 month would be June 2nd, back 2 months would be May 2nd, back 3 months would be April 2nd. Does that make sense?
Yeah, we're doing a whole full
Doing
month,
a whole
and
full
then
month.
you get to your actual July 2nd.
Yes. So
Gotcha.
you're going from that date. So July minus one, July 2nd, back 1 month is June 2nd, back 1 month is May 2nd, back 3 months is April 2nd. So
Hmm.
then you add your 7 days, and that's April 9th. So when you're calculating it, just make sure you're going from the actual like day and you're counting the entire previous month before. What is the most reliable way to determine the gestational age and due date?
Is that by like the ultrasound, like the measurements?
Ultrasound. Yep. So that's when it gets a little bit fun. I mean, so I'm currently pregnant and due in May. So when went in, they did my like due date by using Nagel's rule. That's what they do whenever you call them or they call into your OB. But then whenever you go for your first OB appointment, they will physically measure the fetus to get your actual due date. So that is your most reliable method. Does that make sense?
And that changes also like you know, sometimes you go in and they measure the baby and they're like, oh, okay, like you're measuring this time. And then you go again and they're like, oh, you're measuring ahead of time. And so it switches by like a couple. Is that all just due to the measurement of the baby? Like,
Yeah, it is. So like this is a little extra. You guys definitely don't need to know this, so don't stress about like writing it. But in the first like OB appointment, what they do is they measure that fetus from what they call crown to rump. And on the ultrasound, based on that length of that baby, it gives you 7 weeks, 4 days. And then they would either change a woman's due date depending on how close it is to that fetal measurement. So, like for me, I'm going to use me as an example because I don't really care and it's, good so you guys have something to say. My LMP was August 4th. So they did the Nagels rule and that put me at a May 11th. And then what ended up happening was I went in to get measured, and I think my ultrasound measurement was only off by like 4 days. So they kept my due date as May 11th. If it's anything, a window greater than like 6 days difference, then they're going to go off the ultrasound. Most of the time, they're changing an ultrasound or a due date because a woman has either like questionable like lengths of periods. So like if she has irregular periods, sometimes it's hard to go off of an LMP. So like a patient with PCOS or a patient who has like some other type of medical condition where they're having irregular periods, it's harder for them to go off of LMPs because it's not as foolproof, right? But if you're a typical, like you have a 28-day cycle or whatever, your LMP is going to be pretty accurate. Okay. But like I said, that's a little bit of extra for you. Okay. So Abby's pregnancy test is positive and her ultrasound shows an intrauterine pregnancy with the due date consistent with her LMP. What information are we going to want to obtain from this patient during our interview? Whenever we're talking to the patient and we're assessing her, what are some things that we are going to want to get?
like know her support system?
Mm-hmm. Yeah. What
We
are
would
some
want to we would want to know where she is mentally. Like, did you want to have this baby? Were you looking forward to being a mom? Like, how do you feel about it?
Mm-hmm.
And then that'll let us know what resources we need to bring to her. Because overwhelming her with resources is probably not going to be the best idea.
Yeah, especially if she's an adolescent, right? Because we remember Abby in this scenario, she's 17.
Oh yeah, Abby probably wasn't trying to have this baby then.
She's
Um,
she's here for her first appointment and we want to get what other stuff do we want to know about her?
what is her support system like? What's her living situation like? We
Medical
gotta get her
history.
health history to figure out if she's, gonna be a high risk pregnancy or is she healthy enough to even have this baby.
Yeah. So we want to get an extensive health history. That's probably the most important thing when we're first assessing a patient, okay? Do you have any underlying medical conditions? Are you currently taking any medications for any other type of underlying medical condition? You know what?
Drugs she's taking.
Yep, meds that she's currently taking because, like we talked about briefly, there are medications that we might need to take a patient off of during a pregnancy. Any allergies? When was her last period? Chronic illnesses, environmental, like, CJ mentioned, what's her home life? What's her support system like? What is her financial status? What are her concerns for this pregnancy? Any medication she's taking, herbal supplements, that is a big one, and people oftentimes overlook it. But Dr. Zeller's class didn't know this about me, but I worked with Amish patients for a long time. And there are certain herbs that we need to tell patients you cannot take this even as herbal remedies during your pregnancy. Big ones would be like red raspberry until you get towards the end of your pregnancy. Red raspberry leaf tea will stimulate uterine contractions and cause women to start contracting. Um, most of the time, like they tell you to stay away from like fennel or any like St. John's wort. You guys see that all the time. That's like an NCLEX like go-to gold question.
Also, if she's like a beauty guru or whatever, and she uses like tretinoins and stuff like that, that can be like very teratogenic to the baby. So
Yes.
How about surgeries? Was
Um,
surgeries under health histories?
like what surgery she's had in the past?
Like past surgeries.
Yes, that would be considered under your health history. Yep. Which that's actually a really good one to bring up because for some patients who've had in the past like a LEAP procedure, do you guys know what a LEAP procedure is? That's done. What happens was when they take a small part of the cervix and for like any type of HPV or cervical cancers or testing. So if they do a LEAP procedure or something like that, the woman would have a constrictive band on her cervix, which could impact her delivery, her labor and delivery process. Again, you don't need to know that. That's just background info. Um, but yeah, surgical history is a huge thing to think about whenever we're assessing a patient for sure. Okay. Let's see if there's anything else. Mental health. That is a big one. CJ talked about it a little bit too. If this patient currently has a mental health history, is on medications for mental health. So, like a lot of medications that patients may take for like schizophrenia or bipolar disorder may be unsafe in a category C drug for pregnancy. So, we need to talk to them about that. Um, Education, what their education level is like, if they're planning on traveling, because if they're traveling to a country that requires specific immunizations, sometimes that's not safe in pregnancy. So, we need to know that. Immigration status. Mostly we want to know that because we want to know if they've been previously immunized or if they've been exposed to other things that may not be as prevalent in America. Our cultural assessment, right? Because that makes us a more well-rounded nurse if we take into consideration our patient's culture whenever we're providing them with care. We're doing the assessment for any abuse or human trafficking. Our socioeconomic factors, what would fall under that category?
Like
Uh,
income,
Income?
upper
where
class,
they
middle
live.
class, lower class.
Yep, you got it. Yeah. Socioeconomic factors would just be like financial status. We need to have a conversation with them about that. Um, any abuse of substances or alcohol, we need to talk to them about that extensively. Cigarettes and vaping is another one we want to talk to them about for sure, because all of those things can impact a pregnancy. We are not here to be judgmental. We are not here to miraculously make them quit whatever they are using. We just need to know this for the health of the patient and for the safety of the pregnancy, right? So that we can give them the education that they need. A BMI, so we need to get an accurate height and weight. Because, like we talked about on that first slide, obesity can lead to hypertension. And on the opposite side, a patient who is malnourished, that can impact a pregnancy too, right? Malnourishment can cause intrauterine growth restriction. It can cause issues with the mom whenever she is like developmental difficulties for the fetus. So, nutritional status and BMI is important. What is their exercise regimen like? You're going to have patients who some people are huge into like CrossFit and they're not willing to give that up. They are going to do this during their pregnancy. It's what they've been doing the entire time. And you know what? That's fine. Nowadays, OBs are very much, if you've been doing it before you were pregnant, you are okay to continue doing it during your pregnancy. If you have a patient who's more sedentary and doesn't work out as much, we need to talk to them a little bit about, it is healthy to get up and walk about an hour every day during your pregnancy. That's helpful and it's beneficial to the baby. We want to talk to them about their nutrition. This is specifically important for a patient like Abby, and why is that?
She's young.
She is an adolescent pregnancy, so nutritional intake for adolescents is going to be a little bit different than it is for any other type of pregnancy. Are they taking their prenatal vitamins? Are they getting a good source of folic acid, whether that's through their prenatal vitamins or if they're not wanting to take prenatals, then we need to encourage them to increase their diet with some green leafy vegetables and like kale, spinach, things that are high in folic acid. Because what does folic acid prevent developmentally for the baby?
Oh God. Oh.
The neural tube.
Yes, the neural tube
Good job.
defects.
Thank you, because I was lost.
Awesome. Great work. Yeah. So, folic acid, increasing a pregnant woman's folic acid is going to decrease an infant's chances of having neural tube defects. We want their family health history. We want to know if there's any birth defects present in her family. So, does she have any relatives with Down syndrome? Do we have any relatives that have MS or Duchenne's syndrome, muscular dystrophy, anything like that? If they do and they have pre-existing risk factors, then we might need to encourage them to do that carrier testing. Okay. Um, any type of chromosomal abnormalities that we should be aware of. If they did do that carrier, that genetic testing, usually we get that full panel at the OB office and we can see it. So we want to be able to go through that with that patient. All
Like
right.
the question you ask as a nurse are kind of questions you would ask your partner in terms of, do you have a history of this going on with your family? You know what I'm saying? So you can have an idea of what to possibilities when it comes to having children together.
Yeah, like that's definitely a conversation to have. Especially like if you are trying to conceive or you've already conceived. Like what are some things that are existing in your family? What is your health history? Things that
Mhm.
like most maybe not nurses ask their partners, like but us nurses, we are gonna be like, hey, like what else do you have? Like what do you have a history of cancer or something on your side of the family? Just so we know. Or any type of chromosomal abnormalities. Yes, we definitely want to talk about that.
Well, it's about being proactive and not reactive. So
Yeah,
that's
definitely.
the point.
Considering risk factors, what assessment and testing would you anticipate for Abby in the first trimester? So, what kind of risk factors does she have, first of all?
Like STIs.
Yeah. As like what we know of Abby, right? What would be some of a risk factor or some things that we're thinking about when we first meet her?
Her age.
Her age is a big one, yeah. Um,
I would wonder how she manages her stress level at this age and, being a mom.
yeah,
So we talked about blood pressure going up and being a problem at some point.
yeah. Definitely. The other thing too, which um typically like for being your first pregnancy, that's something also that we would take into consideration. It's her first time being pregnant, so that's also something to think
Her
about.
blood type.
Yeah. So we have them all listed here. So like what Josue was saying, we definitely want to do the full workup for any type of like our blood work for any type of STDs, STIs. We're considering what's her weight, what's her nutritional status, getting her vitals, getting a urine, right? Because we want to test for any glucose or protein that is present in the urine. What is her blood type? Any type of carrier screening we may have done. So our alpha fetoprotein, because we want to know what those are. And then adolescents have that increased risk of anemia and low birth weight babies. We need to know that. And that is simply because of nutritional intake. Okay. So before we get into RH and ABO compatibility, let's go ahead and just take like a short break. If you guys want to just take like 10 minutes, I just really have to go to the bathroom. That is probably my pregnancy bladder here talking. But if you guys want to just run to the bathroom, let's meet back in 10 minutes, okay? And we'll finish through this PowerPoint. Sound good?
Yeah.
Thank you.
Yeah.
All right. I'll see you guys soon.
I don't want no YouTube. I don't want no YouTube. I'm gonna do these too. Oh, man.
All right. If everyone wants to start making their way back in, let's go ahead and finish through this PowerPoint. All right, we'll give some people a couple seconds because I want to make sure that everybody comes back on screen. There are a couple people who had gotten off screen a little before we went on break. So I'll just give them a couple minutes and then we'll get started.
What's on the screen is not any in our PowerPoint, right?
Right. This one's a little different. Yep.
Okay. 'Cause I've been following along with the PowerPoint, but I didn't see it in here.
Yeah, this one's an extra slide. This information though is on the PowerPoint that I went and did a recording on, and it's also talked about extensively in your textbook. So I would definitely spend some time going through this information because there's some practice problems at the end of this PowerPoint that I really want us to get to. So I'm not going to spend a huge amount of time talking about RH and ABO incompatibility. Okay. This is some stuff that I want you guys to review on your own as well. So let's see. Linda, would you mind turning your camera on? Same with Natalie, Miriam, Janaea, and Tiffany. I'll check back in on them in a couple of minutes. But okay, so whenever we're talking about RH and ABO incompatibility, this is a really important thing that I want you guys to understand. So when we're talking about here, there's different kinds. So ABO incompatibility, this is referring to if mom has an O blood type, her blood does not recognize A or B antigens and could detect A, B, or AB blood types in the baby as foreign substances. So with this kind of incompatibility, the mom's body may have already have antibodies to other blood types, and these can attack the red blood cells of the baby with any blood type other than O for the current pregnancy. So,
Professor,
yeah, what's up?
can you please repeat everything?
Yes, I basically just read what is on the slide down here underneath, but I know you guys don't have this on yours, so I'll go ahead and through it again. So basically, if mom has an O blood type, that blood is she is going to start
I'm
making,
back.
sorry, what?
No, I'm back. I'm sorry.
Oh, no worries. Welcome back. Okay, so if mom has an O blood type, regardless if she's O positive or negative, her body is going to start making antibodies towards other blood types. So what that means is that her blood is not going to recognize an A or B antigens and could detect A, B, or AB blood types in the baby as foreign. This is bad because that mom's blood and body may attack the fetal cells. Okay, so when we're talking about ABO incompatibility, that's what we're talking about. So if mom has an O blood type, positive or negative, O positive or negative, her body is going to make antibodies against any other type of blood type. So any baby that may be developing whose blood does not have an O blood type, you run the risk of the mom's body attacking those cells, which can cause a miscarriage. Okay, does that make sense?
There's that shot for it, right?
RhoGAM, yes.
Yeah,
RhoGAM, the only thing that we need to know though is RhoGAM does not help current pregnancies. So that's why, like, usually the first pregnancy you don't run into this issue as much, but for subsequent pregnancies, we want mom to receive ROGAM after the delivery of her baby and then immediately right at the start of her other pregnancy or during her pregnancy. So that is why, like, women who have O blood types, we're recommending ROGAM and we're following up with that a lot closer. Okay.
And
When
that
we
is
talk,
just for O type.
yes.
Okay.
You got it. Um, the other one that is up here, this rhesus D factor, RH incompatibility. So if mom is RH negative, her red blood cells do not have this rhesus D factor. Okay. If baby is Rh positive, the baby does not have the rhesus D factor, and the mom's immune system could detect the positive Rh from the baby's blood as foreign and build antibodies against it. So ABO incompatibility was talking mostly about blood type. This is talking about your Rh, your Rh. Okay. So if mom is a negative and baby is a positive, the mom's immune system could detect the positive Rh from the baby's blood as foreign and start to build antibodies against it. The antibodies will accumulate and affect a future pregnancy if the next baby is Rh positive. Okay. It can also cause erythroblastosis fetalis, which is hemolytic disease of the newborn. That is a really fancy way of saying that this baby can develop anemia and jaundice. Okay. The thing that we recommend for this also is ROGAM. So ROGAM is our standard as far as blood incompatibility. Okay. And then the last one we're talking about is a Coombs test. So an indirect Coombs test tests to see if the antibodies are circulating in the mom's blood. After the baby is born, a direct Coombs test can detect if the mom's antibodies are on baby's red blood cells. If the Coombs test is positive, it increases the baby's chances of having hyperbilirubinemia, which increases the baby's chances of having jaundice.
What was that? I'm sorry.
It's okay. This is the Coombs and the blood type stuff is a big concept and it's a lot more difficult. So an indirect Coombs test checks to see if that mom, if she has antibodies that are circulating in her blood, whether it's been built up because of a ABO incompatibility or an RH incompatibility, if she has antibodies that have formed. After the baby is born, they do a direct Coombs test, and this will detect if the mom's antibodies are on baby's red blood cells. Okay? Why would it be bad if mom's antibodies are on the baby's red blood cells? The answer is that it causes that baby to have hyperbilirubinemia or jaundice. Which this, I almost wish we talked to you guys more about this later in the class because hyperbilirubinemia is something we talk a lot more about during our labor portion. Um, but we talk about it now because it affects pregnancy.
You said that word a lot, haven't you?
What'd you say?
You said that word a lot, haven't you? Hyper
Yeah, hyperbilirubinemia. Yeah, don't ask me to spell it. I'll say it all the time, but
hyperbilirubinemia. I give up. That stuff. Jaundice got it.
Does it go more into detail in the book about this?
yes, a lot more detail. So please go into your book if you're having a little bit of difficulty with it. This PowerPoint, this slide here, I think is good because it kind of breaks it down a little bit more, like just makes it a little bit more understandable. So if you guys want to take pictures of this or whatever you have to do, please feel free. Okay.
Are you going to post this video?
I'm gonna post this video. Yep.
Okay.
And I'll send the recording to Penny so that she can post it for for her class. All right. So here's our friend Abby again. Here's her vitals over here. She's at a visit. This is not her first visit anymore. This is a subsequent visit. Her blood pressure is 110/70. Her weight loss, she lost 4 pounds. Her urine sample was normal. Her fetal heart tones by Doppler were 140 beats per minute. Her blood type is B negative. She tested positive for gonorrhea. Her hemoglobin was 9, so we need to know our normals, right? So that is low, which indicates that she has anemia. Her alpha fetoprotein was elevated, so that means that she has a high risk for her baby being born with a neural tube defect. So, right, we talked about that alpha fetoprotein. So, if it's elevated, that means the baby's at risk for a neural tube. If it's low, that means the baby's at risk for Down syndrome. So, her AFP was elevated, so we're at a risk for a neural tube defect. And then we do all of her other testing, and it turns out she's rubella non-immune. How would the nurse address Abby's weight? How would you talk to Abby about that in a kind in a kind way? How would you talk to a patient about her weight?
You could ask her if she's worried about, gaining a lot of weight with her pregnancy, or if she's worried about how to make her body look afterwards.
Mm-hmm.
I would ask what she eats, how she's been eating, her nutrition and stuff like that.
Yeah.
I would ask her if she has, what does she know about, does she have a set goal? How much would you like to weigh? What do you know about weight gain during pregnancy? What to expect. And then, yeah, kind of then we can go from there, I guess, in terms of what we give her. We gotta know where she's at with this. I guess that's a nice way of saying it. Like, what's your diet like? Do you exercise? How do you feel about coming up with an exercise routine?
Yeah. Definitely. And with her being an adolescent, we're a little bit more concerned about weight loss because we want adolescent pregnancies to gain weight. Sometimes we want them gaining more weight than normal pregnancies. So assessing her nutritional status is a big one. So we're gonna, like you guys talked about, talk to her about expected weight gain. Potentially, we're gonna assess for like any dietary preferences. Is she like developing pica? Because like, if somebody's anemic, what do they crave? What do they always eat?
Ice chips.
Ice chips. So if she says, I just cannot stop eating ice, then we're going to be like, yep, so we need to increase, like, give you some iron supplements. Okay. We already know her hemoglobin is 9, so she's already probably going to be getting supplementation of some sort. And then a dietary consult. If we are able to, this is a patient who would benefit greatly from a nutritionist. So we need to get that started for her. What should the nurse plan to administer at 28 weeks based on her blood type?
Rogam.
Rogam, yep, because she's B negative. She's got that negative RH, which we talked about in the previous slide, that RH incompatibility. This isn't ABO incompatibility because her actual type is B, but she has a negative RH, so we are going to administer her Rogam. What important follow-up treatment and plan would be implemented because of the gonorrhea infection?
She would need repeat PAPs, right? After.
What's the question again?
What important follow-up treatment and plan would be implemented because she tested positive for gonorrhea?
Antibiotics.
Antibiotics, and then they'll probably do a follow-up after to make sure.
Yep, definitely.
Can gonorrhea travel?
Yep. So we're doing antibiotics. We're also going to educate her, right? This is a younger patient. We need to give her some good sexual education.
No more.
Now, now what's recommended is even if a woman comes in and tests positive for a bacterial like yeast infection or like bacterial vaginosis, their recommendation is now to have the partner on medication as well to prevent reoccurring exposure and reoccurring diagnosis. So that's all things that we need to talk to Abby about. We need her to understand these things and why we're concerned about them during pregnancy and how it can affect her baby. What else are we going to talk to her about as far as her anemia? Some things that we would educate her on.
Foods that she probably needs to eat that would help her as well.
Excellent.
Make sure she's taking
Like,
iron supplements.
yes, or eating leafy greens.
Yep. All that good stuff. Definitely. So, how to take her iron. The usual treatment is for 3 months. Don't take it with milk, tea, or coffee, right? Because that can interfere with the absorption of the iron. You want to increase the citrus fruits and juices that you take with it because that helps with the absorption. And then tell her it can cause constipation. Pregnancy, these women are already experiencing constipation. So if we're giving her an iron supplement, we probably should be telling her to take Colace twice a day. Her AFP is elevated, indicating a possibility of neural tube defects. What could have decreased the risk of a neural tube defect in her?
Folic acid.
Love it, guys. Awesome. So proud. Yep, folic acid. So, oftentimes, this patient, like we said, she's younger. She may not have anticipated necessarily getting pregnant. That does not mean she did not plan this pregnancy, right? But what their recommendation is now is for women to start prenatals even before they're trying to conceive, to already give them a good base of that folic acid because it is so important in preventing neural tubes. All right.
Did you see there's a study and basically, when you have the baby, you stop taking your prenatals. Um Obviously you're not supposed to, but you do. The lack of folic acid because you're used to getting so much folic acid a day. The lack of folic acid is actually what causes these major postpartum depression episodes in women.
Yes, I have seen that. So now what they're saying is to do your prenatal until you're done breastfeeding. So yeah, I did see a big study about that. I think I don't know if it's been clinically trialed officially, but there's been a lot of publications about that for sure, about folic acid. And is it actually really necessary in pregnancy? And currently they're saying it is, mostly for this neural tube stuff, because the neural tubes are prevented by it so well. But yeah, after pregnancy, now the providers are telling women to keep taking their prenatals. Yeah, it is very interesting. All right, so what is our next possible step in evaluating the elevated AFP? So we have an elevated AFP. That means that this patient is at a high increased risk for a neural tube defect. What now? What would you anticipate? We're gonna want to.
Don't they usually test the father also for that?
I'm not 100% sure on that. I know they're probably going to have further testing, but most likely this patient's going to be referred to maternal fetal medicine or a higher risk OB so that they can do more extensive like anatomy scans earlier to see if she is developing this.
For the neural tube defects, does this mean the procedure will be like the spina bifida or surgery or something like that?
So the baby could potentially be born with the little opening
Spina
in the
bifida.
back, the spina bifida, which will require surgery. Yeah. So this patient, if this baby is diagnosed with a neural tube defect, which we can see in ultrasound, or like we said here, an amniocentesis, this patient, like, she's going to have to go to a higher risk OB/GYN if she's not already. She's going to have to deliver at a high risk facility if she's not already doing that. She's going to have a lot more ultrasounds, a lot more follow up. This pregnancy is going to become a lot different than what we already were thinking it was going to be. So, with our amniocentesis, what are some important things that we want to know about that? When are they done? When do we not do them?
It can put you into preterm labor. I do know that.
Mm-hmm.
Not before 15 weeks.
Yep, definitely not before 15 weeks. And why?
It can mess with the baby or rupture the sac.
Yep, it can cause miscarriages. Yeah. For moms, our biggest thing with amniocentesis that we're worried about is we're worried about hemorrhaging, right? We're worried about her having cramping. We're worried about her going into labor. Amniocentesis are pretty intense. They're very invasive. So these are things that we're using only as a last resort. All right, and what about her non-immune status to rubella? What are we going to do about that?
Would she have to get immunized?
Give the chickenpox vaccine, right?
It would be the MMR.
The MMR.
MMR.
Yep. So, but she has to wait to get that vaccine until after her pregnancy, because that one is not safe for her to get during pregnancy. So her MMR for the rubella, that's the measles, mumps, rubella vaccination, she'd have to get that in the hospital after she delivers her baby. It's safe in breastfeeding, but you can't have it during pregnancy. You guys are doing awesome. We're almost at the end of class. If we don't make it to the practice problems, I will post them in the course cafe. And then in a couple of days, I'll post the answers to them. Okay? Just so you guys can still get the practice. What other prenatal testing or additional testing that's done routinely throughout pregnancy will Abby be educated about? So what other kind of testing do we do in pregnancy?
Glucose test.
Yeah. Mm-hmm.
Genetic testing.
Yep. Potentially the genetic testing. So we're also talking about ultrasounds, right? 20 weeks for her review of symptoms, which would be like her anatomy scan. That's the really big one. First trimester for her gestational age to test her to see like if their LNP matches. Her glucose test is going to be done between 24 to 28 weeks to diagnose gestational diabetes. Our Group B strep test. This is one that we do. Group B is a infection or bacteria that is already pre-existing in vaginal canals of women. During pregnancy, if Group B is present, it's dangerous for the baby whenever they're delivering. So we need to know if the mom is Group B strep positive, because if she is, she's going to receive antibiotics during labor. We do this at 35 to 37 weeks. And the way that you do a Group B strep test, for those of you who have not had a baby before, is the provider will take a swab and swab the opening of the vagina and then take the swab down to the opening of the anus and swab around that. And then they send it to test for the bacteria. We wait to do that later in pregnancy so that like if there is bacteria that's formed, there's a high presence of it so that it can be detected on the swab. This is not like women don't notice it. Like you can have Group B and it's normal flora, but for babies it has a risk of neonatal mortality if a mom is GBS positive. Okay, does anyone know what the gold standard of antibiotic is that we give women if they are GBS positive?
Amoxicillin,
Yeah, antibiotics while they're delivering the baby.
like broad spectrum.
So we give them penicillin G. So yeah, So penicillin G is the one that the go-to for Group B. What kind of
I'm
assessments?
allergic to penicillin. Is there another one that works like as good?
Clindamycin is usually the one that they do. Sometimes like I believe it's usually clindamycin or penicillin. What assessments will be done at each visit? And then what is the purpose of each? So, like at each visit, what can you anticipate a mom having done?
Like protein in urine,
Yeah, definitely.
glucose in urine.
Yep.
Doppler for heart rate.
Yeah.
They measure the belly,
Yep.
weight, vitals.
Yep. Vitals. I want to talk about that one. Our blood pressure. We're getting that every visit. And if it's elevated, then they might do some additional testing. That's like cut off down here. But yep, our vital signs are weight, fundal height, urine. Those are things that we're going to do. Um, let's go through this here. So, like some normal discomforts of pregnancy. This is why this slide is up. Normal discomforts would include all of these things here. So, our breast changes, urinary frequency, fatigue, nausea, and vomiting. They're going to be more emotional, pigment darkening, palpitations, faintness, heartburn, constipation. This sounds like one of those really bad, like, side effect commercials you see on TV that are just like listing literally every single thing that you could potentially experience. So,
Be honest, pregnancy is definitely that commercial. So,
yeah, there are some crazy things that happen. So if you guys have an exam, most of the time the things that you can see as far as normal discomforts of pregnancy, pretty much anything goes. But these are the biggest ones. They're the ones that are the most common and the most complaint about. Potential problems. So these ones are things that would be things that can still occur during pregnancy that don't necessarily mean something bad is happening, but they are things that we're going to look into way more closely. So, bleeding. Anytime there's bleeding in pregnancy, we're going to be a little bit more concerned about it, especially in that first trimester, right? Because if they're having bleeding in that first trimester, is it indicative of a potential miscarriage? That's the biggest thing they're going to be worried about. Bleeding into the second and third trimesters, do they have a placenta previa? Which is what happens when the placenta lays right in front on the top of the cervix. And so, like, it's like you have your cervix, you have the placenta, and then you have the baby. So, if that woman were to start going into labor, that placenta is going to be delivered first. And that is a huge no no because the placenta is what carries the oxygen to the baby. So, if that placenta detaches and we have a placental abruption and it's being delivered before the baby, that's a big deal. Leaking fluid before 37 weeks. That could be like her water is broke. She is going into labor early, preterm labor. Any decreased or absence of fetal movement. Fetal movement is something that you guys as nurses are going to want to educate your patients on extensively. A woman should feel 10 movements within 2 hours, every 2 hours. If she's not feeling at least that, then she needs to go and be evaluated. The other thing, too, that we need to tell a woman, though, is you're going to learn your baby's pattern. If the baby is moving less than they normally do, that is cause for concern and it should be evaluated. Heartburn with a headache. That is bad. That's a big one for preeclampsia. When we start talking about preeclampsia, our heartburn with headache is one of the big signs and symptoms of preeclampsia. Same with epigastric pain. All of those three things can indicate that she has preeclampsia or is developing some issues with that. Flank pain, especially in the first trimester or second trimester, can be indicating preterm labor. So we want to educate our patients on that. A severe headache that's not going away with Tylenol, can be indicative of preeclampsia as well. Persistent severe vomiting, that hyperemesis gravidarium, would be a problem because we're worried about their hydration status at that point. If they're not able to keep anything down, then that's an issue. Let's see. Burning on urination, that could be a UTI. Any visual disturbances, blurring your spots, could be indicating high blood pressure. Contractions or pelvic pressure prior to 37 weeks could be indicating preterm labor. And then unusual cravings. And when we say that, not like Doritos dipped in sour cream. Like we're talking, I'm gonna eat toilet paper or pica when you're eating ice chips. Okay. Some additional testing and assessment that we might see would be our non-stress tests, which I talked about in my lecture, contraction stress tests, which I also went over. I went over all of these things. So our BPPs, our fetal kick counts, our Leopold's amniocentesis, and then our ROGAM administration. So all of those things can be additional testing and assessment that we may need to do for these patients, just depending on how their pregnancy is progressing and what we're seeing. Okay. As far as like when Abby might need any of these above, it would mostly be like, so for like an NST or contraction stress test would be like if she complains of decreased fetal movement. Same with the biophysical profile. The fetal kick counts and Leopold's are things that we're going to be doing as sometimes as a standard routine assessment. And then we talked a little bit about that amniocentesis and ROGAM administration. Okay. Abby is now 34 weeks pregnant. She realizes she's not felt her baby move today. She's been monitoring fetal movement at home using what she thought was taught at her prenatal appointment. So how is she monitoring? What would her monitoring be?
She should be laid on her side, left side, and she could drink some orange juice and see if that helps as well.
Yeah.
So laying on her left side, no?
Yeah,
And
you want to lay. Mm-hmm.
or how you say 10 every 2 hours or so?
Yep, you got it.
Yeah, perfect.
So when we're talking about how mom is monitoring her baby's movements, that's just referring to our fetal kick counts. Okay. It's supposed to be done at the same time every day, and the goal is 10 movements in 1 to 2 hours. So then, like what you guys were saying, if she does not feel her kick counts and she's only feeling one kick in an hour and she lays on her side and assesses longer but does not feel any movement, she calls her doctor. What is that doctor going to tell her to do? You guys kind of said some of them. But
Drink orange juice, take Tylenol, sometimes a warm bath depending on how far along they are.
Yeah.
Or go in and get checked out if they feel very uncomfortable about it.
Yes, yes. So like you guys said, yep, laying on the left side, drinking a lot of fluids. Sometimes like even changing positions. If she's been laying on her left side, try the other side. But we don't want women to try and do these things at home for any longer than 30 minutes if they're still not feeling fetal movement. So we want her to come into the clinic for monitoring. So she gets to the clinic, she's placed on the fetal monitor for a non-stress test. Abby's fetal heart tracing has minimal variability and no accelerations. Would this be considered reassuring or non-reassuring? Non-reassuring. A reassuring normal non-stress test, which is something that you guys are definitely going to want to know. We want to see a baseline between 110 to 160 beats per minute. We want to see moderate variability, at least 2 accelerations that last more than 15 beats by 15 seconds, and no decelerations. So you guys definitely should know what a reassuring NST requirement looks like, which would be all.
The baseline between beat per minute, you mean the heart rate, right, of the baby?
Yes. Yep, fetal heart rate.
Okay.
Yep, so we want our fetal heart rate to be between 110 to 160 with good variability and at least 2 accelerations. Okay. We go a lot more in detail about fetal heart rate tracings during the labor portion, which I believe is week 3 or 4. And we go through like fetal contraction monitoring, fetal heart rate monitoring pretty intensely. So we'll go cover that.
Yes, please. Yes, please. And all about all this variability and like the accelerations, like I never get it. So I really hope.
We'll go through it a lot. We will go over it till we're all blue in the face for sure.
Perfect. Thank you.
So now that we know that she's had a non-reassuring fetal heart rate NST, what test may be performed now based on that tracing? Like, what else are we gonna do? What other kind of testing would we do for this baby?
Would you do an ultrasound?
Yeah. And what would we
Uh,
do? Like what
it's the contraction stress test, no?
we could, yes, to see how that baby responds. But
Or what the non-stress test would be, no?
yes, that is what we did. We did this non-stress test. Let me see.
I mean,
Yep.
I guess you do a stress test. You need to see if the baby's in distress because everything is abnormal at this point.
Yeah.
Fetal K counts.
Yes, and that is what she was doing at home when she came in. So she was like, "Oh, my movement kind of sucks. Like I'm not getting any movement." So she came in and we did an NST. So whenever we talk about potentially getting an ultrasound, what is something we can do via ultrasound that assesses how the baby is doing?
You can do where you can see
Probably.
the blood flow through the cords.
We're gonna do a biophysical profile.
Biophysical profile was house right here.
Our BPP. So our BPP, if you guys don't know what all of this we're testing for, it kind of looks like Batman when you put it in this mnemonic, Bat MN. So we're testing for fetal breathing, AFI, which is your amniotic fluid index, tone, movement, NST. An indication of fetal compromise is if they score low on a BPP. So, what is our score on a BPP? What is it out of? You guys know?
Do you want a 8 or higher?
You want an 8 or higher. Yep. It's out of 10, but anything 8 or higher is good. It means that our baby should be doing okay. All right. So we're kind of getting into our practice problems here. Let me see. Okay, let's go over this one here together. All right, we'll do a couple of these. We're almost done with class, so we'll just finish these out. Any of the ones that we don't get to, I'll post in our course cafe, and then I'll post the answers a little bit later this week. So a pregnant client comes to the maternity clinic for a prenatal visit on June 6th. Her last menstrual period was December 10th. At which measurement does the nurse expect to find the fundus? How many months pregnant would she technically be?
6.
So were you able to look at what our fundal height should be per month?
Is it 3 centimeters per month, and then the last month is 1 centimeter per week?
Yeah, I believe so, yes. So our answer for this would be 26 centimeters, which is what our fundal height should be. All right. A woman's last menstrual period was on April 1st of 2019. She's been keeping her prenatal clinic appointments regularly, but she states she needs to alter the dates of a future appointment because she and her husband are going on an ocean cruise vacation for the New Year's celebration from December 30th through January 7th. The best response of this nurse would be
C.
Yep. Perhaps you might reconsider scheduling your vacation around Thanksgiving rather than New Year's. She's getting a little bit too close to her due date if she's going on December, right? So we're going to see if she can move her vacation. The nurse is counseling a client who's at 6 weeks gestation and is experiencing morning sickness, but does not want to take any meds for this discomfort. What herb is likely to help with the nausea?
A.
A.
Yep, ginger. Yep. When reading the obstetrical history of a client who's currently at 36 weeks gestation, the nurse notes that she has had one full-term infant, one premature infant born at 32 weeks gestation that survived, and one miscarriage. What is her gravity?
C.
She is
4.
4. Yep. So we have this pregnancy currently, which is one. She had a full-term infant, which is her second one. She had a 32-week gestation baby that was born and lived, which is her third pregnancy. And then she had a miscarriage, which is her fourth pregnancy. You got it. Which topic is most important for the nurse to include in a nutritional teaching program for pregnant teenagers?
A.
C.
C.
We're worried with them about that iron deficiency anemia because our biggest concern with adolescents would be our anemia or low birth weight infants. So that's why we're going to be worried or talking to them about this.
You said with adolescents, we want them to probably kind of overgain weight a little bit just in case.
Yeah, we're going to want them to gain a little bit extra weight or at least gain appropriate amounts of weight because we're going to tell them they need to increase their calorie intake by, I believe it's an additional 500. Don't quote me on that. I would have to look that up specifically what it says in the text. But we do tell them to increase their diet, their calories more than that we do an average normal pregnancy. Okay. We'll do one
You
more.
said
Sorry, what
you
was that?
said for adolescents, it was anemia and what else? Low birth weight?
Low birth weight infants. Yep. We'll do one more question here and then I'll let you guys go. Okay. So during the 32-week antepartum visit, a primi gravida, which primi gravida means that this is her first
Pregnancy.
First live birth.
Yep, first live birth, complains of a backache. Which assessment finding indicates that this complaint is related no, prima gravida means first time being pregnant, sorry, first pregnancy. Which assessment finding indicates that this complaint is related to a common discomfort of pregnancy that occurs during the last trimester? What would be normal in the last trimester here?
A or D?
A.
A.
Who got thrown off by that word lordosis? Anyone know?
Mhm.
That is
No.
It's
Well,
the
I wasn't
curve
gonna
in your
get
back.
the curve in your back. Yep, the curve in your back that can happen during pregnancy because of the way the baby's growing and how everything is shifting. Yep. All right, guys. So you guys all did awesome. Like I said, I'll post those questions that we did not get to today in Course Cafe. For Dr. Zeller's class, I will send her the practice questions that she can send to you guys. So if you have any questions or you need to, or you want to meet with me, please don't hesitate to reach out. It was great to meet all of you that aren't normally in my class. It was nice having you here today. I hope you guys have a great rest of your week and thank you so much.
Thank you.